Welcome to the Strong AF podcast. I'm your host, Dr. Natasha Barnes. I'm a strength and rehab coach for climbers, and I blend my 24 years of expertise and experience as an elite level climber, competitive powerlifter, and rehab professional to bring you a podcast that will help you become stronger and more resilient. In this podcast, we'll talk about all things strength training for climbers. We'll also talk about climbing injuries, rehab, and why training and rehab go hand in hand. To connect, be sure to follow me over on Instagram at Natasha Barnes. To find out more about coaching or getting help with an injury, check out my website at natashabarnesrehab.com. And now, let's get to the episode. Okay, you guys, welcome back to the podcast. My microphone's not working, so I hope the sound is okay. If not, I don't know, you're just gonna have to deal with it. But I'm here for another episode. I'm here with Annemarie Everett. She's a DPT. She's a friend of mine. She's a colleague. She's also a former client, and she's someone I really, really trust when it comes to pelvic floor health. She has a lot of knowledge in this area. So I'm really, really excited to talk to her about this stuff today for you guys. So welcome to the podcast, Annemarie.
Thank you. I'm stoked to be here.
Do tell us a little bit, for people who don't know you, tell us a little bit about who you are, like what inspired you to get into like pelvic floor health and all of that with your background.
Yeah, so I'm a Bay Area native, born and bred. Went to grad school in San Francisco and earned my DPT 10 years ago, which is pretty cool. And I actually ended up falling into pelvic health before I even graduated with my DPT. I ended up taking an elective course with a mentor who was working at UCSF and really fell in love and felt like I had a real aptitude for it and excitement for it. And at the time, especially 10 years ago, it was really new. Like this whole specialty was so nascent. I can't even believe what it looks like now. There's so many more people who know about it and are practicing in it. But at the time, honestly, like the orthopedic world felt a little bro-y to me and felt like there wasn't really a great space for me there. And pelvic health just seemed like a really unique opportunity to dive into a niche that was very uncommon and very needed at the time. So that actually shaped, I ended up spending the first 5 years of my career working exclusively in pelvic health. So I did the thing that maybe you shouldn't do, which is specialize right off the bat. but ended up doing about 5 years in private practice with that same mentor. She hired me out of school and worked exclusively in pelvic health, especially focusing on perinatal care. And then after 5 years, spent another 5 years or so working in outpatient orthopedics, again, primarily specializing in pelvic health, but at that time kind of moved my practice to more of a hybrid MSK care and pelvic health, seeing everything that came through the door for this group, working on site at a couple of large employers in the Bay Area, and also working in private clinics. So I've done a lot of patient care, again, primarily in pelvic health, primarily women, but did treat some men and trans folks as well. And at this point, I actually have transitioned out of patient care. So there is life after patient care for folks who are interested in expanding professionally as well. But yeah, really did my time working in pelvic health and the residency programs and educational programs that I stumbled upon along the way.
That's so cool. So much experience in this, which is like the big reason why I want to talk to you about all this stuff.
Yeah, I feel really, really lucky. I think one of the big problems with disseminating quality information about pelvic health is that it's really hard to get one-on-one mentorship. It's really hard to get intensive residency education. It's really, really challenging to just get the basic training that people need to be super confident in navigating this world and interpreting the research and data that we have and working with patients. And I just feel extremely fortunate to have had the education that I had. I really wouldn't be where I am today without the mentorship that I was able to work with and receive. And I know that's not the typical experience for most folks coming to pelvic health and physical therapy. So all that's to say, I think that's the ideal situation, of course, to like really have somebody to hold your hand and help you. But I think most people are really cobbling together an education, and I commend the folks who are doing that a lot largely on their own.
Yeah, that makes sense. Yeah, that's also why you're such a gem, because you've gotten a lot of mentoring and have had a lot of experience in this field. So really excited to talk to you today about all of this. Before we hop into like the general topic, I just have like a general question for you, like in terms of like your work experience, like what's been the most rewarding part about working with people with pelvic floor rehabilitation?
I think it's probably twofold. There's one aspect of it that still really surprises me every time it happens, which is the impact of a little bit of information for people. In that most folks who ever came through my clinic door had absolutely no familiarity or relationship with their own pelvic floor or like pelvic anatomy or their own genitals or whatever. Like there
Mhm.
is such poor sex education and physical education for pretty much everybody in this country and elsewhere, that a lot of folks would come in with just like no concept of what was happening, no concept of what their anatomy was. And even sitting with somebody and talking through, this is how like peeing and pooping work, this is how sex works, this is how your anatomy looks. We're like looking with a mirror. It's like real vagina monologue stuff happening in some of these appointments. Like it's really powerful because you realize that like nobody has ever sat down with any of us and like explained these things step by step. Like literally
Yeah.
no one. And so the impact of being able to have those conversations with people, it just rocks their world and it's so empowering. And so that's not even like the complex, like, let's debate whether it's okay to lift heavy with a belt or whatever. This is literally just like, do you know what your vulva looks like? And people don't. And so you get a
Yeah.
chance to really create that experience for them. And it is pretty amazing. I think the other piece of it that is a far more recent change in the way that I was working with people, and I know that you identify with this too, is the ability to surprise people with what they can do physically, and maybe
Oh,
even, beyond physically, but creating experiences for people um, to realize that they're stronger than they thought they were, or more capable than they thought they were,
totally.
and to have these experiences that really show them that they can be like resilient and try hard and work hard and like see results from that. And I know a lot of different kinds of professions are able to create that experience for folks, but that was certainly by the time I left patient care, my practice had changed a lot, and that was something that um, I thought was very, very valuable and rewarding.
Yeah, totally. That's really cool. Very on brand for what we do here. Oh, for
I was
sure.
like, I'll feed this bias. Yes, I know if we're on the same page here.
Yeah. And also like, yeah, how empowering. I feel like nobody teaches us how to understand our bodies. And like, even with the work that I do, like, just teaching someone like how their body moves or works, or just giving them a little bit more understanding can be really, really empowering and game changing for them. And I can't even imagine what that's like for like the pelvic floor area or the genital area, where like we're not supposed to talk about that. And people don't even look at their
Yeah.
own genitals sometimes. And like, we just don't have, I think as a society, it's just sort of like a little taboo. So
Yeah. And I don't want it to sound either that I like came into it fully enlightened myself. I think that was the thing I had to also deal with along the way. I had a lot of learning that I had to do in many different ways, but I also came into it and was like, ugh, like I suddenly have to confront a lot of my own feelings about my own body and like like, how do I think about sexuality? How do I think about these things? How comfortable do I feel even saying these words out loud to people? And I grew up quickly, I think, in a lot of ways. I felt so young when I started, and I had to like get good at all that stuff pretty quickly. And so personally, it was also like a huge learning curve, but obviously very valuable too.
Yeah, that makes sense. I feel like when you're a clinician, it's like you got to get over bodies really quickly. Like some of my
Yeah.
friends are like, "How do you get over touching people's feet?" I'm like, "I don't know. I don't care. It's fine." Like,
Yeah.
you know what I mean?
Yeah. You're like, if that phased me, I wouldn't have lasted this long at all. Like, you got to
Yeah,
get over that so quick.
totally. I'm like, obviously, you don't have any friends that are nurses either, so like,
Bless them. Yes.
yeah. But okay, so let's get into the podcast here and some of the topics that we want to talk about. So, the first thing that I want to dig into is just helping people understand the pelvic floor a little bit. So, I was wondering, I know it's kind of hard over podcasts because we don't
Yeah.
have like any visuals, and like me, I don't know, maybe I can like try to post some visuals or something later on Instagram or something like that. But can you explain just like the basic anatomy of like the pelvic floor?
Yeah. Yeah. I'm switching into pelvic PT mode, and we normally have our little like pelvic model that we bring out and show to people, and I like so desperately want to do that. Um, but I would describe the pelvic floor muscles as a hammock of muscles that sit inside the opening of the pelvic bowl. So if you think about the core as we understand it, we have the diaphragm at the top, which is kind of this upside down umbrella shape. And then we have the abs and the back muscles that make the sides of the core. And then if you just take the diaphragm and flip it and put it on the bottom, that's what essentially the pelvic floor does. Main difference there is there's also some openings in the pelvic floor muscles and loops of muscles that create the sphincters that keep everything in and let it out when we need to pee and poop. So I would just call it the bottom of the core and also the thing that lets things in or out. There's a lot of complexity about the muscular anatomy, but I think it's simplest to understand as a deep layer and a superficial layer. So the deep layer is really the muscles that contract and lift up towards the head and shorten when they contract that way. The superficial layer is the layer that I would think of as when it shortens and contracts, it contracts inwards around the openings. So it's the thing that controls what goes in and what goes out and when. The really interesting thing about the pelvic floor that I think is a nuance that a lot of people don't consider is that it's on all the time, right? Like it's not something that's just like off or on. And people ask me sometimes, should my pelvic floor be on or off for this thing? And my answer is, you don't get to decide that.
Yeah.
It's just doing its thing. And so I've settled on this metaphor of a dimmer switch instead of a light switch to
Mm.
understand like what it is doing. It's a postural muscle. It's just like the deep abdominals. It's just like the deep back muscles. There's a lot of stuff that's humming along in the background for us to keep us upright and not just like, you know, like those toys with the string in them that fall down. All of that is happening on this kind of unconscious level, and it's turning up and turning down based on what your body needs to stay stable. And the pelvic floor is a postural muscle. It is doing that as well. And so it's a really, really subtle feed forward feedback mechanism that reacts to what you're doing, anticipates what you're about to do. And it's far more complex than something that you just think about, should I be contracting it or should I be relaxing it? It also has, you know, its own automatic functions, right? You're not thinking all the time, don't pee, don't pee, don't pee, right? But
Yeah.
it's got some resting muscle tone there, and you're not peeing all the time. You're only peeing hopefully when you want to. And it's just reacting to things like coughing and sneezing, hopefully again without you thinking about it. And so much of that is going on in the background. And one of the big things that comes up in pelvic floor rehab is this idea that you have to quote unquote retrain your pelvic floor, or you have to start doing something different all the time with your pelvic floor muscles. And that irks me a little because
Yeah.
the idea that we could kind of sit in the driver's seat of all of this highly complex, um, very graded mechanism of how these muscles work is crazy. Like we could never be as good as our spinal cord is at doing all of that work. So that's my little soapbox there. But I just think it is a special group of muscles. It's also a group of muscles that is very similar to every other muscle group that we're familiar with in the body. But it is this really complex postural player in all of this.
Yeah, thanks for explaining that. That was a really good, like, basic explanation of the pelvic floor and like thinking of everything almost like a box and it's the bottom of the box. I like that
Exactly.
analogy. I also like that you pointed out that it's like not always something we can like consciously think about contracting or that we should. But I feel like it's like the pelvic floor is like this black box for people because it's like kind of not well understood to most people. Um, and I feel like what you're describing is similar to like when people say like, oh, like, if your back hurts, it means you're not like turning your core on, you're not keeping your core engaged with everything. And we're not supposed to be like engaging our core like all the time with everything that we're doing. That would be crazy, right? And like
Yeah.
same thing with pelvic floor, like we should be thinking about it like that. Or like some people will be like, oh, my PT told me like I need to like fire my glutes more. Like my glutes don't fire. So I'm thinking about squeezing my butt all the time. I'm like, you don't really want to be having to think about that, like our bodies kind of got us in the background most of the time unconsciously for things.
Yeah, I mean, I feel like in the beginning of my career, and I will be very upfront that like a lot of this, I didn't come out of school having the same convictions that I have now. I think many of us have had to do our own learning journey along
Yeah.
the way to correct a lot of these myths that unfortunately advanced schooling still perpetuates.
Yeah.
Um, but the idea that any of us should come like clomping through with our very like heavy-handed, I'm going to contract this muscle here and contract this muscle here and like change how my body has created motor patterns to be able to execute any of these movements is so wild to me that we think that we can and should be like changing how that works without
Yeah.
really appreciating how subtle it is and how kind of perfectly tuned a lot of it is. And our body's just like doing its thing. It's doing its best with what we give it, right? So like let's give it
Yeah.
more and let's talk about some different strategies that we can choose, but saying that we know better than these like finely tuned mechanisms is pretty crazy to me.
Yeah, totally. Well, we're going to get into some of that too. The next question I wanted to ask you was like, what are some of the warning signs of pelvic floor dysfunction? So I feel like we've been hearing about pelvic floor stuff more, especially like in the climbing realm. We're starting to see people talking about it more. I would love to hear like what are the warning signs of pelvic floor dysfunction and also like when somebody should seek professional help and maybe also maybe too many questions at once, but like how does it affect climbers, like because obviously a lot of climbers are going to be listening to this.
Yeah, yeah. Well, let's break it down. Let's start first with the signs of dysfunction. Um, I think I will also put a big disclaimer on this that like I think in the MSK world in general, people go trying to borrow trouble. They go looking for things that are wrong, like, oh, so and so
Hmm.
said my posture looked imbalanced or whatever, or like this shoulder is half an inch higher than this shoulder. And we're borrowing trouble when we go looking for things like that because bodies are weird and asymmetrical and like they are going to do what
Hmm.
they're going to do. And so a lot of people try to find pelvic floor dysfunctions. They'll be like, oh, something must be
Hmm.
wrong with me. I have to figure out how to like optimize my pelvic floor. And I
Hmm.
think my advice is basically like, don't look for pelvic floor problems when you don't have them. If you have symptoms, like, yes, I think that's a good reason to get help or at least to kind of monitor and keep your ear to the ground and see what else is going on. But I don't think everybody needs to like have a pelvic floor exam to be told how optimal or not optimal their pelvic floor muscles are. If you're just taking care of your body and doing resistance training in the way that we need to be doing and doing cardio in the way that we need to be doing and like generally eating and drinking well, like you're going to be okay. so, so don't go borrow trouble when it comes to your pelvic floor. The pelvic floor generally is related to bowel, bladder, and sexual function. So when things start to go awry with bowel, bladder, or sexual function, I would say think about the pelvic floor being involved, but don't assume that it is. And I think this is the really hard part about identifying problems and getting people to the right clinicians, because we are in the pelvic health world, we're these weird hybrid providers between like an MSK physical therapist, a colorectal person, a urologist, a urogynecologist,
Yeah.
an OB-GYN. Like we have to have kind of amateur levels of knowledge in all of these areas to be able to differentially diagnose and to be able to understand kind of where our scope of care is going to be with this person. So a lot of issues that involve bowel, bladder, and sexual function are best addressed with a pelvic floor PT. But it doesn't mean that the reason you're having those problems is because of pelvic floor muscle dysfunction.
Mm-hmm. Yeah.
Is that fair? Like,
Yeah.
maybe you just have a terrible diet, but like,
Yeah.
you know, your constipation could be dealt with by talking and working with a pelvic floor physical therapist about all of the things that can improve constipation through diet and lifestyle and have absolutely nothing to do with your pelvic floor muscles, simply because that's a great person to work with. They're highly accessible. They have a lot of knowledge. But, it doesn't mean that everything that involves those systems is down to muscle dysfunction. So I think that's a helpful clarification.
Yeah, that makes sense. What kind of symptoms would we be thinking of here for people? Like I know urinary incontinence can be one symptom, constipation. What symptoms are we talking about here?
Yeah, so any leaking of urine or stool, which means urine or stool coming out when you don't want it to, whatever the situation, or difficulties fully emptying, right? So we have issues that are the opposite of incontinence, basically urinary retention or the feeling of urinary fullness and urgency, as well as like constipation, for example. So anything that shouldn't be going in or coming out, like that's a fair symptom to get evaluated. Sexual challenges are even more complicated. They are so fraught with so many different factors that influence things, but I would say an easy rule is that if something hurts when you're having sex or something hurts in the genitals in general, it's probably a good idea to start first with a medical provider, because there are so many acute things that can be causing issues. And certainly, if you see skin changes, tissue changes, there's itching, there's discharge, like that's probably not a pelvic floor problem. It's probably a medical problem. Not always, but probably. And so I would start there. But if you're having more chronic pain issues, deeper pain issues, things where you've seen lots of other providers and no one's been able to give you an answer and you haven't seen an MSK-based provider, I think that's a good candidate to go to a pelvic PT for an evaluation. So it's so murky, right? And I think that's one of the challenges is there's a lot of right answers to who you should go to for some of these problems. I think a lot of the issues stem from bad referral networks. So like people not recognizing when they should refer on or not having somebody to refer to for those problems. And I think that's where patients get tripped up and not getting to actually the resources that they need.
Yeah, that makes sense. There's so many things that could be going on that may or may not be, appropriate for musculoskeletal or, another specialist. So
yeah.
Okay. I mean, that provides a little bit of clarity. So I think that makes sense. I think people will kind of know, hopefully, when they think they should go see a pelvic floor specialist, but you never know. I mean, I've had people come in to see me. I've had, when I was working in person, I had someone come in and they were like, oh, I have this like really bad neck pain and like kind of going down my arm and like, and immediately I'm thinking, oh, okay, this person just has like some referral or like maybe some radicular pain coming from their neck.
Yeah.
And I'm about to do my exam and I just catch a glimpse of this like rash on their neck. And I'm like, do you have a
Oh.
rash? And I like pull their shirt up and look, and they're like, oh yeah, I also have this rash. And it like goes all the way down my shoulder, all the way down my arm. I'm like, oh my God, you have shingles. Like,
Yeah.
I can't help you with this. It's actually very contagious and you need to go to your medical doctor.
Oh
Like,
no, I know, I know. It's just so hard. And then like providers, when all you have is a hammer, everything you see is a nail, right? And so it's also this like cognitive bias that when somebody comes to you, you want it to be your problem, right? Like you want it to be the
yeah,
thing that you treat. And
you want to help. You want to help.
yeah, of
Mhm.
course. And so you'll keep like hitting your head against that wall thinking, oh, it must be this, it must be this. And so as a patient, I would just say, if you're not seeing progress, like get another opinion because you could just
Yeah.
be barking up the wrong tree, especially with a lot of these symptoms.
Yeah, totally. So would it be safe to say that if people are having like any kind of incontinence, it's probably safe bet to go to a pelvic floor specialist. If they're having like pain with sex, that could be depending. Or if they're having like deeper
Yeah.
pelvic pain, maybe that's like pelvic floor. But if it's something maybe more superficial or there's other symptoms involved, maybe that would be better for like a medical provider.
Yeah, yeah. Sexual pain is tough, honestly. And I think having a good relationship with a gynecologist or urologist or a primary care provider is one of the better things that we can do, just because your hope is that that medical provider will say, I don't know what this is, but I think it's a pelvic PT problem and like send you on your way,
Yeah.
as opposed to telling you you're crazy, right?
Yeah.
So that's the downside. But yeah, I think urinary incontinence is probably the most straightforward. There's very few like acute medical problems that are going to cause you to leak, and usually the leaking uh, doesn't come out of nowhere, right? Like it sort
Mhm.
of makes sense given what you know about your life, right? Like maybe you're pregnant, maybe you just had a baby, maybe you know this about yourself that it goes with your cycle or whatever. Like there's usually some other context to it.
Mhm.
So I would very rarely say that urinary incontinence is a like medical first evaluation.
Okay. Yeah, that makes sense. Have you worked with climbers when it comes to like pelvic floor health, or incontinence or anything like that?
So I haven't, I'm thinking about, I don't think I've ever seen anybody coming to me specifically for climbing related incontinence, but I think the and I hope you'll agree with this. I think the general principles for any athletes are really, really similar.
Yeah.
And I think the name of the game for leaking, well, to be clear, for stress urinary incontinence, and we can talk about the differences, but stress urinary incontinence is a very mechanical problem, and is directly related to intra-abdominal pressure changes, which is this common anytime anybody's trying hard in any sport.
Yeah.
That's the common denominator. So I think a lot of the same principles are going to be very, very similar across sports. But you have certainly a different vocabulary to be able to understand when those intra-abdominal pressure changes are happening, right? If you're trying to
Right.
explain to your provider what you're doing and they can't picture it, I think
Right.
that's hard. But I certainly, as a very amateur climber myself, I can say that
I wouldn't
I've
say you're
seen,
very immature. I wouldn't say that, but
well, whatever the step is right above that. I would say that I myself feel okay, these are the moments, and like it makes sense for sure, why somebody would have leaking. Absolutely.
yeah, okay. I forgot to mention when we started the podcast that Annemarie is a climber. She climbs so regularly.
Yeah, yeah,
So yeah,
yeah.
more
When
context
I
there
have
for
time.
people.
Yeah, yeah,
Yeah.
yeah. I got this new job and I'm like, oh man, I can't go to the climbing gym in the middle of the day. Like, what's up with that? It's
That is a
terrible.
bummer. That's the best time to
Yeah,
go.
I know.
Okay, so are there times when people might be having pelvic floor symptoms where maybe they don't need to seek professional help? For example, like I have had, and maybe this is TMI for the internet. I kind of don't care. It's fine. It's not TMI. I don't care if people know this. Like when I lift really heavy, and we can get into like lifting heavy in a second and all of that, how that affects the pelvic
Yeah.
floor. But sometimes when I'm lifting very heavy, like very maximally, especially if I'm like under recovered, or sometimes if it's during like a certain part of my cycle, like I do leak. And it's fine. It doesn't happen all the time. It happens like every now and then, and it doesn't really bother me. It's just something that happens when I'm really heavy, when I'm lifting really heavy, and I haven't felt the need personally to like go get help for that, because it's just like infrequent and I know when it's going to happen, and it doesn't feel like there's something wrong with me.
Yeah, and I think that is the key, right? Like you understand it to be, the word quirk is a little flippant, but like I know my body has quirks, right? Like and I think anybody who is pushing their body's capabilities on a regular basis and who has, as a result, a decent body awareness, like I think we'll all discover something that's like not perfect about the way that we experience our body, but it's maybe predictable and not worrisome. It's not progressive. It's not linked to anything else. And we can kind of let it be the thing that it is and not be alarmed about it. And I think that is part of the thing that frustrates me about what I would call awareness building in the pelvic floor community at
Mm-hmm.
large is in our attempt to try to help people feel validated and understood for the symptoms that they're having and not have shame about them. We've maybe over indexed on the like, it's common but not normal, and like you should always get help for these things, and like symptoms are always the sign of dysfunction and you don't want to have dysfunction, right? And I think
Mm-hmm.
think there's I think that is too far. I think we
Yeah.
have to validate, right? Like so many people are embarrassed and ashamed by symptoms like that. And that, of course, has its own downside. It makes them not want to participate in things that they love or care about. And, I think, especially speaking about women and girls in sports, like there are
Mm-hmm.
so many reasons for women and girls not to participate in sports that like I don't want this to be another one, because
Right.
we've tried to make people aware to the point that we've told them, oh, now this is a problem you have to go fix in order to safely participate. I don't
Right.
believe the data bears that out. And so I think validation is very different than um, diagnosing dysfunction that must be dealt with. And at the end of the day, like we're all adults with autonomy to make our decisions about what we care about. And like if your symptom of leaking like really bothered you and it was like, I know this is safe, I know my body's not in danger when this is happening, but it makes me crazy and I hate it so much, like you could do things to make it not happen. But do you have to do those things? I think it's
Right.
arguable, right? And so
Right.
I think, I would have a different discussion about symptoms related, certainly to like bowel function. I think there are risks associated with like having horrible constipation and terrible bowel habits for your whole
Mm-hmm.
life. Like I do think that
Mm-hmm.
can come back and bite you, for example.
Yeah.
But again, I can't force people to deal with it if it's not a problem that they perceive to be a problem in their life. But I think a lot of these things, like many MSK issues in general, like you can live a full and happy life with these symptoms. And if you're fine with it, like nothing terrible will happen to you. You won't die from these symptoms, right? Like we need to
Yeah.
all like take a second and chill about identifying and treating dysfunctions. I think there's a time and a place for giving people solutions, and I think that has to be separate from validating, hey, that does happen. That's super super common. Like that happens so often it might actually be called normal, right? Like this is a
Yeah.
spectrum of normal experience. And you are a normal human being, and that is a very reasonable thing for your body to experience. And like, there's nothing to be embarrassed about. And I think we can say that conversation full stop, and then we can offer solutions if people want it. And my solutions and my urgency around those solutions is different depending on whether I think there are downstream effects that that symptom can have. Again, like constipation is the perfect example. Um, and I will make those known to people, but none of this stuff's going to kill you. So,
Yeah, that's really good to hear you say. And I'm sure some people are feeling really relieved. I feel like, the pendulum can swing a little far in one direction sometimes. And I have heard people say online, like, oh, if you're leaking at all, that is a symptom of pelvic floor dysfunction. And like, you need to get that fixed. It's common, but
yeah.
it's not normal. And it makes you feel like, oh my God, like there's something wrong with me. But like, I deal with this all the time in my rehab practice. Like, people have pain. They come to me because they have a
Yeah.
symptom. The symptom is pain, and it's like, it's normal to have pain when you're training really hard. Like, it just happens and we can manage around it. Doesn't mean something's wrong with you. It doesn't mean like we have to fix your posture or like, something like that. It just means that, like, okay, yeah, you're training hard. We kind of found a ceiling for your body that's not tolerating whatever you just did. And let's modify around that and keep going. There's nothing wrong with you though. It's a normal reaction to
Exactly.
stress.
Exactly. And this could be its own podcast, but I think the population that I see, I just feel so much for the perinatal people that I have worked with and that I know are out in the world now dealing with all this information about the pelvic floor if they have that information. And there's so much pressure on people to like fix their pelvic floor now in a way
Yeah.
that's really crazy to me. Like we went from having no information, no validation. It was just suck it up and deal with it. Like we won't even talk about your problems, they're not important, to we know you have these problems. This is common, but not normal. Let me nitpick every single thing about the way that your body moves and make you think you have to relearn everything you've ever known about exercise and everything you've ever known about your body. And you have to do all of this while also being a new parent. And like, it's just way too far in the other direction. And like, I think we just have to let people also not be 100% optimal in their physical performance and be like, yeah, that sucks. That's hard. Like, that's a big change for your body. And like, it is annoying and embarrassing and not something you want to have happen, to leak when you're in exercise class or to have an accident in the middle of Target. I've heard that so many times. And like we have to separate the validation conversation and the empathy from the solutions piece.
Yeah.
And that's where I feel like it's getting a little mixed up. So I want everybody
Yeah.
to know that if they leak or they have pooping problems or sex hurts or whatever, that like you're actually normal. Like these things are so common that I would feel bad calling them not normal. Like I have a job, I had a job full time treating this stuff because it's so common that I would have to call it normal. And
Yeah.
it's on the spectrum of normal human experience. And like you're still living your life. These things are happening at the same time. And like there are often very good solutions for them, but like you never have to deal with them. You can deal with them when you're ready or when you want to deal with them.
Yeah, I'm really glad that you said that. You mentioned that, like, it seems like sometimes now people go looking for dysfunction. Like, there's almost a little bit of confirmation bias. So
Yeah.
that's sort of, I want to talk about that because that sort of leads me into a like kind of the biggest question I wanted to ask you for this podcast. We'll get into other questions too, but the next question I want to ask is like, what are some common misconceptions you see around pelvic floor health? And like, can we talk about that? Because I feel like I've seen some pretty wild things being said about pelvic floor health, about like what you should do about it, if you should do anything about it, like just everything. Like, can we just sort of talk about some big misconceptions or common ones?
Yeah. Oh my gosh. So I was thinking about this ahead of time and I struggled to pick my top three. But we'll start with those. So the first one I thought of that actually is I saw this a lot in residency education too when I was mentoring and working on the curriculum. And I think again, it's the like bias of where these conversations are happening. Like a pelvic PT wants to be able to apply physical therapy knowledge to try to help with these symptoms. And the way that this profession looks at pelvic floor related symptoms is always trying to find a link to pelvic floor muscle dysfunction. And I think that's just a human bias in the way that we're approaching things. But I think people in the world should know that symptoms related to bowel function, bladder function, and sexual function are absolutely not all caused by pelvic floor dysfunction. Like, absolutely not. And I will give a couple of examples in that I I frequently had the experience of having people referred to me for urinary urgency or urinary leaking, and their primary care or gynecologist would refer them for pelvic floor muscle dysfunction and have already kind of told them, oh, your issues are due to muscles. These doctors hear urinary leaking and they're like, I don't know, pelvic floor, and send them to pelvic floor physical therapy. So we have to do all of the other kind of differentials after that. But it very quickly became clear to me that I had to do an extremely detailed history with everybody who came in for any symptom, because you would hear things like, oh yeah, like I have a lot of urgency and I leak sometimes. And then I would learn from them that in the whole day, they would drink 16 ounces of cranberry juice. And that was it. All day.
That's their liquid for the whole day?
Whole day.
Oh my gosh.
And it's like, like, do you think perhaps this person has a bigger problem than like their muscles can't hold it in when their bladder is finally like, I give up. This is too much. I am so irritated and like whatever that I can't get to the toilet in time. And so for somebody like that, my entire intervention would start with, let's look at your fluid intake. Let's practice getting more water and getting water at all, getting more water, and then spacing out the water in ways that your bladder can handle. And then suddenly, magically, they don't have a urinary leaking problem anymore, because the main issue was never that their muscles weren't strong enough, right? It's that their bladder was so irritated and had such low volume in it that like it was constantly feeling kind of urgent and it was kind of contracting the whole time. And this person had no control over when they were actually going to go to the bathroom. If I had just said, oh, you're here for urinary leaking, it must be pelvic floor muscle dysfunction, I guarantee you I would have found some deficiency in her pelvic floor strength, because I've never met a 5 out of 5 strength pelvic floor. I promise you. Like I've never met one. Maybe one, but for this person, like there's always something you can find, right? Always. And the same thing for MSK care in general. Like nothing is ever perfect. If you go looking for problems, you can always find something to address. But whether that is really the problem you need to be working on depends on your understanding of the whole situation. And if somebody has pretty good strength and you're telling them that they're leaking because their strength isn't good enough, I don't think that's a great answer, right? Like there's got to be something else going on, because most people are walking around with pretty good strength and we're not all leaking. So that's one example. Another example is somebody I worked with who was diagnosed with vaginismus. So that's an old term, but it's basically kind of an involuntary muscle spasming at the vaginal opening that prevents somebody from having any penetration at all. And she had been diagnosed by her doctor. She was trying to conceive. We started working together, and it became very clear that she had severe OCD around feeling like things were coming at her vulva that weren't clean, right? It was a cleanliness phobia and a cleanliness OCD issue. And that was manifesting in, of course, this whole experience being not really feasible for her. She would just like totally lose her ability to stay relaxed, and it just all fell apart instantly every single time. That's not a pelvic floor muscle issue, right? Like, and this person, bless her, she went on to go like get pregnant twice and have 2 kids vaginally, and never quote unquote fix the vaginismus issue, because the issue was around sex and the OCD piece of it, as opposed to like the muscles had dysfunction, right? So I think that illustrates the very broad spectrum of kind of reasons that people came to see me. And it's why I took frequently 40-minute long histories with folks because you have to get to the bottom of all of this stuff. And no matter what the problem was, if it was in my scope, I would work on it, right? But like I was talking about liquids for 45 minutes with somebody. I wasn't touching them. They were sitting in a
Right.
chair, right? And that was pelvic floor PT for that person. And so that's what I want to let pelvic PTs know, that they are free to do that. You're allowed to do that. You don't have to
Right.
go touching everybody all the time for no reason.
Right.
Like figure out what the thing is you have to deal with and then be that provider for that person. You don't have to, again, hammer and nail. You don't have to make everybody do Kegels for
Right.
shits and giggles, right? Like pick the thing they have to do and just do that. Um,
Yeah, I
yeah,
think it's
so there's that.
important to be holistic, like when you're a provider, because often, like even in my field, like same thing, like it's not always, something straightforward, musculoskeletal related, why somebody is experiencing what they're experiencing. It's like, oh, what if we start talking about your diet and your sleep and oh my God, your life is so stressful and like tell me more
Yeah.
about that. Oh my God, this is going on for you. Like I think there's a little more to this than just like your scapula is not moving properly and that's why you have shoulder pain. Like I think there's some other stuff going on here that are contributing to why you're having pain. And we have to
Yeah.
look at it more holistically than that. I think if it's really easy to get like narrow it in on, well, I'm pelvic floor health, so let's just look at that. And like, I'm just going to give you Kegels or whatever it's going to be. Or for me to be like, well, I'm going to just look at your shoulder and we're just going to look at how your shoulder's moving and your posture. And like, that's what we're going to fix because that has to be like why you have pain. We have to think
Yeah.
outside of that. It's so complex and there's many reasons why people can have not just pain, but like all kinds of symptoms that are coming from like stress or psychological things or nutrition or like just not sleeping well or like so many other things. So I'm glad that you
Yeah.
brought that up.
It makes me nostalgic for the early days of my career when I thought that it was that simple. I don't know if you have
Yeah.
that feeling,
Oh,
but
totally. Yeah.
so many days I was like, man, I wish it was easy like that. Like
Yeah.
it's like against all odds, I have to make it this complicated. I just don't want to, but I have to in order to like practice in a way that I think is evidence-based. And you're like, man, I didn't know how good I had it. Just like marching in, being like, I'm going to correct the dysfunction and then it's all going to be better. And they're going to thank me because I will have had magic hands. And then like it's all going to be great. And
Yeah.
I'll do my job and clock out. Um, yeah,
It's nice when it's like
I
that because
love
you're
that. And
like,
I miss that. Yeah.
yeah, you're like, oh, I know exactly what it is. Your L5 is rotated, and I'm just gonna adjust you, and like you're gonna be good. And like, it that might work sometimes because like there's a lot of reasons why treatments work sometimes, and it's not always why we think that they're
Yeah.
working.
Yeah.
Um, and it works for a little while, and you're like, oh, cool, I do have magic hands. And then all of a sudden it stops working because you get a case where it's like, no, it's literally not that. Like, and then you're like, my patient's not getting better.
Yeah.
Maybe I gotta figure this out. And then you start thinking outside the box more because it's like, yeah, fortunately we care about our jobs and we care about our patients and like we
Yeah.
want to figure it out. We're not just gonna like pinhole ourselves into like one thing. But yeah, it'd be
Yeah.
nice if it was simple, but
Oh man, I
bodies
know.
are bodies are not simple. Any other
Crazy.
misconceptions or things that you want to mention here?
Um, this one is a personal beef of mine, is this idea that everybody who's in pelvic PT needs to have an internal exam or treatment. And especially later in my career, when I started seeing more men, um, they would come in and like, I can't even describe to you. It was like they were climbing the wall trying to get away from me, like sitting in the corner of the room on their first visit.
Mhm.
Terrified, absolutely terrified to be there, didn't want to look me in the eye. Like I could tell that it was just like their last resort that they were in my office. And I started to realize that if I just started by telling them that I was never going to ask them to take their clothes off if they didn't want to, that like this huge weight just lifted off of them. Because the whole
Mm,
time that they were like preparing for this appointment, they were like, everybody says on the internet that like they're going to go and put their finger in your butt and like you're going to have this rectal exam. It's going to be so horrible. And they deferred and deferred treatment for months and years and like didn't get the help
Wow.
that they could have gotten because there was this single narrative about what you had to do to get diagnosed and treated. And I think that's so limiting and so awful of a message to send to people because if that is the only way that we can do our job, like we're not good enough at our job. I mean, really. And I'll
Right.
say it that way. Like, if you can't appropriately diagnose and treat a patient without an internal pelvic exam, 99% of the time, I will, of course, leave some exceptions out there. But if you don't have a good enough history and a good enough kind of external exam and ability to like take in that information
Hmm.
without doing an internal exam, like you gotta work on some of the fundamental skills then. And I think a patient being told that they don't have to consent just by walking in the door, they're not consenting to have to do that,
Hmm.
really lets people get the care that they need, have the conversations that they need, ask the questions that they have been sitting on for months and years. And I think we as a profession really need to do better at um, educating patients before they get to us that that's not the we're more than our index finger was like the joke. um but like we should be much better than that, right? And I want people to know that they always have the ability to opt in or out. Like this is a consent based practice, like you should never be told that this is your only option. And you should also know that like you can still get good care. And I think we should be able to guarantee that to patients that like we can still do a very good job. And once I gave myself that permission, like my results in practice didn't change, but my patients got a lot happier, right?
Yeah.
Like I was able to talk through things and make the call with somebody, whether that was the right use of our time. And a lot of them opted in and a lot of them opted out. And guess what? Everyone was fine. Like there was no difference in
Wow.
my outcomes. And if people could just hear one message, I think that would be an important one to hear.
Yeah, that's important. And that's, yeah, patient-centered care, And I think that like, especially when it comes to healthcare, people can be really afraid to like advocate for themselves or like ask
Yeah.
questions because we feel like we're not allowed to like ask our doctor questions or like question medical practices or anything like that. And I think that it's really empowering for people to know they can ask questions. They can revoke consent or not automatically
Yes.
give consent just because they're walking into a medical office. And you do have to be your own advocate when it comes to any kind of healthcare and like be comfortable asking your doctor questions and they should be comfortable answering those questions. If you are getting upset because a patient's asking you questions, like imagine like I don't know, you're not good at your job or you shouldn't have that job because like you should be able to answer people's genuine questions about their health and like their concerns.
Yeah. And like they are your 10th patient that day, but you are their only PT. Or you know what I mean? Like this is the only
Right.
time they've been doing this. Everything is new, everything is scary. They don't know anything. But you're like, to do, just like pop it on my gloves like I do for every other patient. Like this is still something that we need to treat with respect for that person in that
Yeah.
experience.
Absolutely. I love that you said that. Anything else that you want to bring up when it comes to like common misconceptions?
Um, what do I want to pick? I would say this is just to reiterate, we already talked a little bit about this, but it's the idea that everybody needs to see a pelvic PT. Um, and somebody from the APTA is going to be mad that I'm saying this, but like I just don't think everybody needs to see a professional for every problem. I
Yeah.
really don't.
Yeah.
I think we can in many ways put ourselves out of business by empowering people with the information that they need to be able to just roll with the things that happen in life and make choices about how they're going to deal with it. And
Hmm.
I think a lot of the sensationalism around um, awareness around pelvic health issues and let's say MSK care in general, um, we are disabling people by telling them that they need us for everything. And it's okay to be uncomfortable sometimes. It's okay to have these things
Yeah.
happen. Like
Yeah.
if we normalize that normal human experience, then maybe people will still come see us for guidance, and that's fine. But we don't have to have everybody panic when they have a symptom and try to go see somebody. And you have to actively be dealing with this problem and you have to change something about your life. Like, I don't think that's fair to people. And especially in the perinatal population, which is a group that I just spent so many years working with and having a lot of empathy for by the end. I'm not a parent myself, but seeing the spectrum of experience, like it is just so fucking hard. It is so hard. And it's also just so profound, these changes that happen to people physically and physiologically. And I think like we got to cut people some slack. Like we got to let them not be at 100% sometimes. And we have to let them be okay and feel okay about not being 100%. But then we have to
Right.
be there with resources when they need them. And like sometimes my job was like, hey, like, do you know about this new pad that you can wear when you're exercising and then you won't leak through your clothes? And people were like, amazing. That's so great. That's all I needed. And then they left, right? Like sometimes
Yeah,
that's what our job can be, right? Is like enabling
totally.
people to make do with what's going on and be able to do what they care about. And maybe they come back when they're ready to do more, or maybe they never come back because it never becomes a bigger issue for them. And so I think that is also a message, again, really goes with the awareness building, is I am all for education. I think we absolutely need to educate people about how their body works. And that is a personal crusade of mine. It has been for a long time, but at the same time, we can't always tie that education to a guilt trip about it being some horrible dysfunction that if they don't
Yeah,
deal with is going to cause some horrible problem to happen for them, because I don't actually think that that's true in a lot of cases, right? Like these are not
yeah,
progressive, severe symptoms that will come back to bite you later. I really think the most of these symptoms that we're talking about are mild to moderate and totally benign. And sometimes we have to let people live with that. So I think we have to have both of those
yeah.
pieces, but we can't tie the solution to the validation.
Yeah, that makes sense. I think people are gonna love to hear that or maybe hate to hear that, but I feel like you should love to hear that because it's so empowering and it's so freeing to know that like it's okay to be uncomfortable sometimes. It's okay to have symptoms. It's
Yeah.
okay to have pain sometimes. It doesn't mean you're doomed for the rest of your life. It doesn't mean something really bad is happening to you. And it's a normal human experience. And I think the more we normalize it, the less people are gonna like freak out about this stuff. And if you're listening to this podcast and you haven't listened to some of the other episodes that I have on like pain and injury and rehab and posture and things like that, those would be some good episodes to go back and listen to after this one. If you're totally just like, what are you guys talking about? Like, it's okay to have this stuff. Like, yeah, it is
Yeah.
okay. Like, we're human beings. We're not supposed to be optimal. And also, like, optimal so arbitrary. Like,
Yeah.
optimal according to what? Like, I don't think we
Right.
have a model for optimal, like a evidence-based model of like when people come to me and they're like, I think I need better posture. I'm like, according to what? Like, what's good
Yeah.
posture? Like, we don't have a consensus for that. We don't have a consensus for good or bad because it's so variable in the population. And I'm sure it's the same thing with pelvic floor health. There's so
Oh my
much
gosh. Yeah.
variation there. And like, we don't have a normal, like, everything is normal
Yeah.
because everybody has all of these experiences all the time. So,
Yeah. Yeah. And I think the other piece of it is like sometimes the solution to your problem, at least in pelvic health, is like very simple. Like it's like drink more water or like you're doing the right thing. You got to just give it more time. Like all
yeah,
of those answers can sometimes make people upset.
yeah.
And I'm like, wait, but I thought that was good news. And they want something kind of fancier. And
Hmm.
um, and I also think that like pelvic PT, like other parts of PT and MSK care, tries to make things more complicated than they need to be.
Right.
Um, and like I don't think your ankle mobility has a bearing on your pelvic floor function. Like,
Yeah.
and you laugh, but like that's a thing that people have claimed because of a study that came out a while back that like said that your ankle position changed your pelvic floor function, which like,
Wow.
okay, that's, I mean, that's true. It's an observation, but like, does that say that now I have pelvic floor dysfunction because my ankles don't have great mobility? Like,
Right.
that's a very different conclusion to make from a paper that was like, huh, isn't that weird? The pelvic floor activation kind of changes when your foot's at a different angle, you know?
Right. Right. Yeah.
Um, and I like that's the trap. And that's often why I don't want people to going to pelvic PT. And this is kind of the extension of that statement is like sometimes I want people going to a strength and conditioning coach that really knows their shit, right?
Mm-hmm.
Because I
Mm-hmm.
know that person's not going to do something weird with them, right?
Yeah.
Like,
Totally.
my God, like, just like have them fucking deadlift some things instead of like doing weird, blowing up a balloon dead bugs. Like,
Yeah,
just stop
totally.
doing weird shit with people and making it special. Just like do the basics well, but have a very good understanding of what your goal is when it comes to affecting the pelvic floor muscles, right?
Right.
I can be treating the pelvic floor and having people do what looks like a normal gym routine. Like
Right. Yeah.
it's
Yeah.
not that crazy, but I think when I say not everybody needs pelvic PT, I also think not everybody needs pelvic PT like PM, whatever that thing
Yeah.
is that pelvic PT has become. Like, I want to separate like expertise around how to manage pelvic floor related symptoms from like the weird package of things that is often associated with people who work in that field.
Yeah, that makes sense. That's something we often talk about. Like in our professional circle, like sometimes you can't tell the difference between a rehab program
Yeah.
and a strength and conditioning program.
Yes,
And like if
exactly.
you looked at my clients' programs, you probably couldn't tell me who on my roster is a rehab client and who is a just like a regular performance client because the management often looks the same or the programs often look the same. And like maybe the intent is slightly different for the rehab person, but like it looks the same. So on that note, I
Amen.
feel like a lot of people think about pelvic floor treatment as like, okay, like they're going to tell me to do Kegels, or I need to like learn how to breathe properly and like activate my deep core.
Oh,
Whatever it means,
yes.
or like blow up a balloon and do like, that kind of thing. So like
Mhm.
what does treatment actually look like? Or like, I mean, I know you can't give us like you don't have a patient in front of you with like information about their case, but
Yeah.
like in general, like what does pelvic floor health like PT look like for people most of the time?
I will speak to what I used to do and also what I hope I taught my residents to do. I like think about what I really hope they still do based on what we talked about. Um, but I think pelvic PT should have a very healthy component of at least ruling out what I would call lifestyle contributors. So all of those things related to the food you're taking in, your liquid that you're taking in, your sleep, your general like psychological state, and your nervous system state in your life, and also your habits around toileting. And that's a weird thing to say, but like
Mm-hmm.
again, like people were never taught what to do. Like if somebody like were you ever taught how to poop?
No, you just go.
No. Right. Someone just put you in a toilet and they were like, make it go in the toilet. And you're like, okay, I'll do whatever it takes to do
Yeah.
make that happen.
Oh my God, I
Um,
don't know how to poop.
I know, right? I don't know. We all just kind of like figured it out.
Yeah.
And so people will still friends will just like say things to me being like, is that how you're supposed to do it? And I'll be like, yeah, I think that's right. And they're like, okay, great, just checking. Cause like again, like nobody like was told the quote unquote right way or even what normal was or like any of that, right? Like it's just something we've all been blindly searching in the dark to try to figure out for ourselves. And
Yeah.
so, especially when we talk about urinary leaking and urinary urgency, people have all kinds of wild habits around when they go to the bathroom and um, what they do when they're going to the bathroom and all that kind of
Mm,
stuff. And so I really I have to at least rule that stuff out
mhm,
in order to be able to say, okay, is it any contribution from your lifestyle, or is it really just like a muscular dysfunction problem?
mhm.
And it's usually not 0% lifestyle issues, right? Like there's
Yeah,
always some contribution there. So we
totally.
always have some conversation around like, how much water are you drinking? How often are you going to the bathroom? Are you pushing your pee out really hard to try to go really fast when you do go to the bathroom? Like, let's just consider all of those and clean all of that up. So that's one piece. Um, and then some sort of assessment of muscle function, I think, is helpful. I think, um, again, the internal pelvic floor exam, which is done intravaginally or intrarectally, is something that is considered the gold standard for assessing pelvic floor muscle function. And the reason it is because it's the most direct observation and palpation that you can do.
Mm,
Um, but I think there are good proxy measures beyond that that you can use clinically that like it's okay. You don't have to get super, super precise, right?
mhm.
So for an internal exam, it's just asking somebody to squeeze and hold around your finger and assessing kind of how long they can hold, how hard that squeeze is on that, whatever 0 to 5 scale. We sort of have the same thing in the pelvic floor. And that is one way to kind of objectively assess what's going on with the pelvic floor. We can also palpate externally. This is a fun activity for everybody at home, but if you put your fingertips right, like at the base of your tailbone, so like right, not on your anus, but like right above it, and then you do a squeeze, like you're stopping yourself from passing gas, you should be able to feel your tailbone curl in just a little bit. I know we're all doing it. Feel your
I can
tailbone
feel
curl
it.
in just a little bit. Yeah. And everything kind of like draw up and in. That's a way that I've also assessed clinically when people are okay with that level of palpation. I'll do it sitting, I'll do it laying down, but just making sure that somebody knows what up and down are, right? So, like, can you squeeze up on purpose? Can you bulge out like you're trying to pass gas on purpose? And assessing just somebody's awareness of all of that and generally the ballpark of their power and endurance.
Mhm.
And then I also will just kind of assess what's going on if there's a provocative activity, right? So, like, if somebody leaks when they lift something or like has some uh, symptom associated with a movement or activity, that's not different from what you would do in another MSK exam, but it's really seeing it in context because sometimes there's a strategy problem, sometimes there's a capacity problem, sometimes it's a little bit of both. And so being able to actually assess that is really important. Pain is also an interesting one. There's so many variables with that, but um, trying to narrow down the factors around it, right? Like, is this movement based or not? I think a lot of MSK pain is movement based. Some pelvic floor related pain is not movement based, it's still really tissue based.
Mhm.
And I think that's something that's a little bit unique. But I think with that, it's really understanding the context of the problem, making sure you're doing a really good job ruling out all the other medical contributors, and then trying to understand how you can grade exposure, right? Is it through movement? Is it through palpation? Like, what is it? And then how do you help retrain pain mechanisms in that area? So it's all like
Mhm.
very, very, very analogous to what happens elsewhere in the body. It just takes a lot of kind of subject area knowledge in terms of what's happening directly in the vulvar area, for example, and being able to understand that in context. Let's say if the person is postpartum or perimenopausal or whatever, and being able to add all those factors together to know what to do and when.
Got it. So you have to probably be a little bit creative sometimes when it comes to like grading people's exposure back to things that with
Oh
when
yeah,
it comes to pain. Yeah. I know I have to
yeah,
be. It's probably even more so for that part of the body.
yeah. It's creativity and like faking it till you make it in terms of like the like giggles. It just like it's a
Yeah.
funny like you have to be able to talk about sex toys with a totally straight face. Like how do you as a medical provider like talk about everything on Good Vibrations website, right? Like you're literally like looking at that stuff with people trying to be like, okay, will this be the right one? Like, what do you think about this one? And like you're online shopping for sex toys with somebody in the context of a therapeutic environment. And you have to just
Amazing.
be like, we're cool. I'm so confident about this. Like, this is
Yeah.
all totally fine.
Yeah.
But if they're game, I'm game. And I think like that's the kind of problem solving that they often don't get elsewhere. And so if you're a comfortable, safe
Yeah.
space, like it's the same principles. You just have to be able to like navigate that conversation.
Yeah. That makes sense. It's so interesting.
Yeah.
Anything else treatment wise that you want to mention?
Um, I think that again, this is a shift in my own life and my own practice that reflects this as well. But um, I think for me, most people um, really do well with a movement based type treatment, even when it's for pain, and making it as self powered as possible, I think is really, really important. And I say that for pelvic pain in particular, because when pelvic pain treatment first came to be, um, it was so powerful because it was the first time that people with pelvic pain had had access to any sort of treatment and validation and support. And these were folks for a long time who just really had no resources. But the unfortunate part is that pelvic pain treatment is still, in my experience, very manual therapy based, like very, very,
Yeah.
very manual therapy based. And anybody who is diagnosed, in big air quotes, diagnosed with a tight pelvic floor is just massaged to high heaven, internally,
Mhm.
externally, in a way that just like keeps them on a conveyor belt and never like lets them loose out of the nest with any sort of other
Yeah.
tools. And it's the same fundamental problem as MSK in general. But I think the the internal manual therapy thing is so entrenched in pelvic PT that people are coming in. And I will say, I'm the first to say, I did this for a very long time, and it was the way that things were done and the way that things were taught.
Hmm.
Um, but it was people coming in twice a week for 30 minutes of internal pelvic floor massage, intravaginally or
Wow.
intrarectally or both. And
Wow.
that was the treatment. That was it. And that really sucks. Like I hate that I did that, right? Because like at that point you're just waiting it out, right? Like you're making them feel better for a couple of days, of course, and they come back, but like you hope that their natural history of this condition was eventually going to end, because otherwise it's years
Yeah.
later and they're still the same people on your table, and that is very unfortunate. And so I think getting movement involved, getting like voluntary muscle contractions in a painful area going, that is controversial in pelvic floor world. But
Yeah.
I'll let people know I gave people with pelvic pain Kegels and no one died and they got better. Like, you know what I mean? Like, God forbid. Um, but it's like, man, maybe we should like move the part that hurts too. And
Yeah.
um, and that was wild, I
I
guess.
think I think
So
that's really really important. That definitely parallels my experience in practice where like a lot of it right out of school was like manual therapy. It's like I'm
yeah.
doing, manipulations to like adjustments to people. I'm doing soft tissue work on them. And it's great temporarily, like people feel good and but that's how they stay on that conveyor belt. It's like, oh, well, I feel like I have to come in every week or a couple times a week just to like manage my symptoms and they can never hop off the conveyor belt because we're never doing
Yeah.
more than that. And that's when I
Yeah.
started realizing like, oh, I need to like we need to do some movement with people. We need to like build some tissue capacity, tissue tolerance, like do something that's going to help like bring down their pain level and give them a little more like autonomy with their treatment. Not autonomy is not the right word I'm looking for, but like what's the word I'm
Yeah.
looking for? Just
Self-sufficiency at some point.
yeah,
Yeah.
yeah. Like I want them to be able to help themselves. And like I found that people were just coming back over and over and over again, which is great for business. But like I'm
Right.
like, oh, we've been doing this for a year, like or however long. Like this is not sustainable. Like we need to like make some other changes here because we can't just be coming in all the time. And I
Yeah.
think, yeah, it's like the same thing. It's cool to hear. I mean, unfortunately, but like also it's cool to hear that like there's a lot of parallels with pelvic floor. It's not just this black box of like, ooh, we don't know what's going on. It's like this mystical, magical plit. No, it's just like anything else in
Yeah.
MSK. Like
Yeah.
we gotta load you. We gotta make sure your lifestyle factors and other things are like we're looking at that. And maybe we do manual sometimes or something, but if it's
Yeah.
appropriate. But
Yeah. And I know that's been our side channel conversation for a while is like it's okay for the pelvic floor to be like subject to the same scrutiny that we've been scrutinizing MSK care with.
yeah,
Um, like it should not be held separate. These are still the same bodies and like the same muscle fiber types and like yeah, the situation's a little bit different with like the viscera around there, but like it doesn't mean the like skeletal muscle is like inherently different.
yeah,
And I don't want people to treat it as something that is separate from MSK in general. Like I think
yeah,
that is dangerous for it to be treated as totally separate. Um, and it's a bummer that people try to go into pelvic floor. Like I'll say it was a bummer that I tried to go into pelvic floor without a like super solid simultaneous education in MSK care, right? Like I got better at pelvic floor care when I got better at MSK care. And that wasn't till
yeah,
midway through my career. Because this whole time I had just been up in this weird ivory tower of my pelvic floor world, being like, oh no, but like vaginas are different. And they're just not. Like it's a unique field, it's a unique specialty. I know things that my MSK colleagues absolutely do not know and will never need to know, and that's fine. And I'm not saying we don't have a need for specialists, but I'm saying the specialists in pelvic floor should be very competent MSK therapists in general because the
yeah,
principles are the same. And I think that message
yes,
was never given to me in the beginning of my career, and it's still the message. If we keep them separate, MSK therapists now are going to forever cede control over any knowledge in the pelvic floor area to people who are like, oh, those pelvic floor people. And I think that's a
yeah.
problem.
Yeah, and I feel like that's what's happening is like people are like, oh, I don't know, pelvic floor, like go to the pelvic floor people. And then
Yeah.
pelvic floor people are just talking about stuff that maybe they learned in school that's not like totally accurate or
Mm-hmm.
maybe isn't doesn't need to be managed that way, when really it's not very different than regular MSK, which for people who are listening, if you don't know what we're talking about when we're saying MSK, we just mean like, physical therapy, musculoskeletal things that physical therapists, chiropractors, and people like that help people with is what we're talking about. And if you've looked at my content, if you've listened to any other episodes in this podcast, you probably have some idea of like how I like to operate in that world. And it is very evidence based, and it's not like anti-manual therapy, but it is like we need to be doing other stuff here. It's not just about dysfunction and like identifying dysfunctions and correcting dysfunctions. And like we were talking about earlier, my treatments for rehab look really the same as like my athletes who are just trying to get stronger, because most of the time
Yeah.
that's what people need.
Yeah. I had this really awesome client, one of my last clients that I worked with. And he had had years of pelvic pain that was really like changed his life, like had to change a lot of things about his life as a result. And he was young, like I think he was like 25 when he came to see me. And he had Botox injections in his pelvic floor, he had all manner of
Wow.
things. And it was like, it just never got better. It was just bad all the time. And finally I was like, do you want to just like do something different? Like, are you just like sick of all of this? Like, he had just came to me and I was like, well, the good news is for me, you've already tried all of these things. So we just don't even have to waste our time with like
Yeah.
all the things I know you have spent years and thousands of dollars on. So you want to just like exercise a little? And he was like, is that safe? I was like, yeah. And he was like, will it hurt? I'm like, I don't know. Let's see. And like to his credit, he was like, yeah, fuck it, let's do it. And the treatment protocol, again, in big air quotes, the program he was on was just a like tolerance-based resistance training program with movements that he found interesting, but they mostly were like gym movements. He was like, I've always wanted to overhead press. And I'm like, all right, let's do it. And like it kind of hurt his pelvic floor at a certain point, at a certain threshold. And so we just worked kind of around that threshold. And then sure enough, the threshold goes up. And then suddenly he's doing all of
Yeah.
these things that like, because we're not just like putting our finger on literally the sore spot over and over and over again with the same results, suddenly he's like getting his body moving. He's like not constantly thinking about what his pelvic floor is doing and whether it's relaxed or whether it's tense or whatever. And he made huge strides. And I never once did an internal pelvic floor exam. I never once did anything specifically to his pelvic floor because that was too aggravating. But as soon as we just like got him moving and working hard in other ways, we knew his pelvic floor was working and the results spoke for themselves. And he had this higher tolerance. He had better sexual functioning. He had better bowel and bladder functioning. Like all those pieces fell into place. And I think it's just a perfect example of like, again, we don't have to make everything corrective. We don't have to make
Yeah.
everything super special. And like, if I didn't have those tools, I wouldn't have been able to help this person because he had
Right.
already done all of the kind of typical pelvic PT stuff. Um, and I felt very lucky that at that point I felt at least pretty competent as a general MSK therapist who could like prescribe resistance training to
Yeah.
people. And that was what made the difference.
That's
So
awesome. Yeah.
yeah.
I feel like I have so many stories that sort of like parallel that, not obviously not with pelvic floor, but with other areas of the body where it's like, okay, we didn't do anything really special. We just kind of
Yeah.
like started taking care of your body better. We like did strength training. We like made sure we were staying hydrated. We like made sure we tried to get better sleep. We like found ways to manage your stress a little bit better. And like things just got better, 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 better. I never laid a hand on this person,
Yeah.
because
Yeah.
I feel like with body stuff, it's more like, I don't know if you heard of that analogy of like, it's more like a garden. Like, you have
Yeah.
to provide the right environment for like plants and vegetables to grow. It doesn't matter how much sun you give them, how much water you give them, how much fertilizer you give them. They're going to do what they're going to do. All we can do is provide the right environment for that to happen.
Yeah.
And that's kind of our job.
Yeah. And figuring out like, does this garden just like lack sunlight? Is that the thing?
Yeah.
Like, well,
Right.
let's give it sunlight. And
Right.
that is expertise. And I think just thinking professionally about the conversation around like who are any of us in terms of our expertise, like that's the expertise is
Right.
being able to hear this story and identify like that's the thing. And maybe the thing is so simple, it sounds ridiculously silly, but like you figured that out and no one
Right.
else did. And that
Yeah.
is expertise. So when the answer is simple, I think it's great. I don't think it's a sign that your PT doesn't know what they're talking about. I think it's a sign that they actually really listen to you.
Yeah, it's like actually there's a lot of expertise and thought and experience that went into that very simple answer, even though it sounds very
Yeah.
simple. And I do
Yeah.
think that if you are like, obviously if you're a coach, but if you're like a musculoskeletal health specialist, like you should have a strength and conditioning, some knowledge
Yeah.
on strength and conditioning. Like, and they don't teach you that in school. You may have to go
Nope.
out and like and get that for yourself and have that understanding. Like a good therapist is going to be a good strength coach also probably. So yeah.
Yep.
I have a few more questions I would like to ask
Yeah,
you, but I
yeah.
know we're running out of time here. So how are you feeling? I feel like we're definitely going to have to do another episode because
I know.
there's so much more I want to talk about.
I know.
But maybe we can run through like rapid fire a little bit, just like a few more
Yeah.
questions before we end.
Yeah. I'm into
Okay.
it.
So I know I was getting some questions around strength training, and heavy lifting. And I know for some people, like some people leak when they lift heavy.
Yeah.
I had people wondering about like, is it okay to wear a belt? Should they not wear a belt? Like how, without knowing specifically people's cases, obviously, like, are there things people can do if they do experience leaking with strength training, or things they should look out for, things they should do or not do? Anything you can say on that?
Yeah, well, I think it's helpful first to define that leaking that happens during lifting is called stress urinary incontinence. I think in some papers it's actually been called powerlifting urinary incontinence, which I think is
Oh,
silly. It's
it's
all the same.
funny. Yeah.
Um, but basically, that's a mechanical issue where if the intra-abdominal pressure, the pressure inside the core, exceeds the ability of the sphincters around the urethra and the pelvic floor muscles to oppose that, then urine sneaks out, right? So it's basically when pressure down exceeds resistance upward, that's when we have a leak. And so it's a math problem, basically.
Mm,
And there are a lot of reasons why either side of that equation could be affected. One of them is literally the weight on the bar, right? Like it's just when the numbers go up, there is a moment at which essentially everyone would leak, right? There's
hmm.
a hole in the bottom of the pelvic floor. It is when there is a hole, there is always a point at which leaking will happen. I promise. It would be absolutely wild if there was a hole that never opened for somebody,
Even
no
for
matter how
men.
much pressure. Exactly, exactly.
Yeah.
Men leak from both openings as well. So commonly, especially in elite powerlifting, like it
Hmm.
happens because you are basically trying to see how much intra-abdominal pressure you can generate. So it's a challenge. You're laying down a gauntlet for your pelvic floor. And so anytime you have an equation where you're playing with maximal, what maximal is for you, there's a potential that you leak. And the research that I've read around powerlifting and incontinence is basically, and again, powerlifting is the sport that was studied, but let's say strength training or like heavy lifting in general,
Hmm.
um, is that when you go into a lift and it is your heavier lift, it is close to your maximal for that day, let's say, or if you come in under recovered, or let's say you have a very full bladder or whatever, if some part of this equation is not exactly right, then your likelihood of leaking will increase. Um, if it's happening every single time you lift, no matter what weight, like that's one question. But having
Mm,
it be very tied to intensity or relative intensity is very understandable. And I think
hmm.
there are people who will never have leaking, and there will be people who have routinely an experience of leaking like you described that you have. You could almost set your watch by it, right? It happens and you're like, yep, could have told you that was going to happen today because of X, Y, and Z factors. I'm not stressed out by this, right? And so that is one story where I think to me it's a training variable, right? It's one more thing that you experience. Like some of us are like, oh yeah, like my right SI when it's like about to rain, like I feel that the pain in the side there. It's the same thing. Like you know you're going in a little bit run down to your training session, or you're pushing things a little bit higher for yourself, and you know that this is a possibility you're going to flirt with. Like that's okay.
Hmm.
And I
Hmm.
think that that is something that the research also shows as your threshold and your capacity increases, the point at which you leak also increases.
Hmm.
So again, it keeps moving further and further out as your capacity increases. And I think, again, that illustrates that it's exactly what it is, which is an illustration of that maximal endpoint for your body with intra-abdominal pressure. And that could be due to anatomical variation. It could be something that's due to your like childbirth history. So having had a vaginal delivery or not could make that more or less likely for you.
Hmm.
Um, but I would say that's one thing is just capacity.
Yeah.
The other one is strategy, right? So if it's happening all the time, then maybe it's a strategy problem, or maybe your capacity is just really not where it should be, right? Like maybe your
Hmm.
capacity with your pelvic floor is way lower than what you could potentially deadlift or what you could potentially bench or whatever it might be. And so I also think it's helpful to identify when that's the issue. If your strategy can change and it changes the symptom, then it's a strategy problem, right? But if you're doing the great, perfect strategy and you're still leaking, then it's a capacity problem. Then the question is, do you not lift when it hits the point where you leak? Let's say you really have a capacity problem. Is it okay to leak? And I think my answer is yes. I think, and people will come at me for that, it's not true for everybody. I promise. Like, there's always an exception to this. If somebody is not in a vulnerable physiological state, and I'll say that to cover the umbrella of being pregnant, being relatively newly postpartum, having any sort of hormonal reason why your tissues are less resilient to repeated high intra-abdominal pressure, then perhaps that is not the right strategy. But if we have to deal with a symptom in order to build your capacity, then like maybe that's something we have to deal with, because what's the alternative? Right? Like
just avoid it forever. Never challenge it.
Right. And so I think in those situations, maybe we got to do some Kegels, right? Like maybe this person has a capacity problem that is such that they really need to start with submaximal Kegels that let them build a little bit more. But at a certain point, people graduate from Kegels, and the answer to increasing your pelvic floor strength and thickening your pelvic floor muscles is just lifting more, right? Like,
you guys, can you
it's just lifting
that?
more.
Can you please hear that? Like,
I don't know. So even pelvic PTs, I don't think we're taught this, but like, you can only do so many Kegels.
Right.
Like once you can do 10 of them and hold them for 10 seconds and nothing changes in terms of your power and your endurance in those, like, let's move on. Like it doesn't make any sense, because the power you're generating is not going to change unless it's responding to a higher load above it every time, right? And it's directly proportional to your intra-abdominal pressure. So like generating intra-abdominal pressure is the pelvic floor training, because the pelvic floor is responding automatically and consciously when you're adding to it to that. So like an overhead press, a row, a bench, a deadlift, all of those things. Anytime you're just trying not to fall over while you're exerting force on something is a pelvic floor exercise. And the relative difficulty of that is the relative challenge to your pelvic floor.
Yeah, that makes so much sense. And I hope people can understand that, because it's pelvic floor. It's like when I have people who are like, oh, I hurt my rotator cuff, so I have to do really specific rotator cuff. I'm like, or we could bench press. Like we could bench press, and like that's going to strengthen your rotator cuff, or push-ups if we have to start with that, or whatever, you know. Or and like with your example with Kegels, it's the same thing I run into with bodyweight exercises for people. It's like, cool, once you can do 10 push-ups, then what? 20 push-ups, 30 push-ups, 40 push-ups, 100 push-ups. Like, no,
I don't have time for that.
Nobody wants to do that. And it's not getting you stronger. It's just getting you to do more push-ups. So how about we bench press so that we can overload it in a way that's like ergonomic for you, that's like progressible. Same thing. So, okay, maybe we start with Kegels, but like now we need to actually start loading your pelvic floor with the lifting so you can get that exposure to those higher intensities and like continue to get stronger in your pelvic floor, because it's a pelvic floor exercise. Like,
yeah. And like, I'm also just going to say this to like add to people's excitement about it. Like, running is also pelvic floor exercise. And arguably, it's an even higher level of pelvic floor reactive contraction, because those ground reaction forces are really high. When your foot hits the ground, that's a lot of force.
I think it's like 7 times the force in your knee or something like that. 7 times your body weight force through your knee.
It's wild. And so you see these graphs of what the pelvic floor does. Bless these people who ran with pelvic floor sensors in, by the way. But like, we're
Yeah.
indebted forever for this. Um, but you see the spike in pelvic floor activity to higher than what you could generate voluntarily, much higher, every time your foot hits the ground. So, like, that's really fucking cool. Like, running
Yeah.
can be your exercise for your pelvic
Yeah.
floor. And like maybe you do some cross training with some strength training to be able to build up some capacity there so your body has more to use when you're running. But like
Yeah.
running can be therapeutic. Hopping can be therapeutic. Like we have to talk about
Yeah.
where the thresholds are for your symptom and what our comfort level is with pushing into that threshold based on your own personal medical history and all of those
Hmm.
things that might influence risk profile, I would say. Like how risky do we want to get? How far do we want to push into symptoms? But like the thing that causes the symptom can be the therapy if you grade it, right?
Yeah.
Like
Yeah.
it's all the same
The dose makes the
conversation.
poison. So
It does. It does. And one of the first instructors I ever had is one of the first people who started doing pelvic PT in the United States. And she is still very much alive and kicking and not that old. So that's how
oh,
that's how old this profession is.
yeah.
But she used to say, tell your patients to pad up and play on. And it was basically this idea that like, I don't care if they're leaking. These people, everybody needs to be physically active. And we
Yeah.
cannot make somebody unhealthy to save a vagina. Like,
Yeah.
that's
Yeah.
not, we cannot do that, right? Like, we can't just
Yeah.
be like, okay, you can't exercise until you can do it without leaking. That's insane. That's
Yeah.
insane. And so I think I love that philosophy because it gives people permission to get strong and have symptoms while they are getting strong.
Yeah.
And again, there are always exceptions to this. That's a whole other podcast about like what medical histories people might have to navigate. But for general population, like the exercise, a graded exposure to exercise can be the therapy to deal
Yeah.
with the symptom. And I've known plenty of postpartum people who are like, oh, I never saw a pelvic PT. I just went back to my personal training and then
Right.
eventually my leaking went away. And I'm
Right.
like,
Yeah.
weird, crazy. Yeah, that's
Yeah.
how it works. Like
That's
you
all you really
just
needed.
gradually expose yourself to exercise again and your muscles recovered and like everybody was happy.
Yeah.
So that's the lesson about strength training is I think it can bring on symptoms. It can be the provocative factor for sure,
Hmm.
but it is the best thing you can do for your pelvic floor. If you're not doing it, you are doing your pelvic floor a disservice.
Yeah.
And I really don't want people to confuse the occurrence of leaking with a dysfunction.
Yeah.
And that's another hill I will die on. Is like I think it
Yeah.
can, I'm happy to die on that hill.
I love it.
Because there are many dysfunctions that can lead to leaking. And I'm not saying that's not true. But if the reason you're saying somebody has a dysfunction is that they are leaking with a maximal deadlift, like I don't think you understand the math.
Right.
And I think it's
Right.
just math. And
Right.
there will always be leaking that happens at some point when somebody is working at their max. And athletes are going to encounter this because they're working at their max. That's the whole
Right.
deal. And
Yeah.
most of us don't like resting. So, you know what I mean? Like, you're
Yeah.
like, damn it, I have a rest day. I hate this. Like,
Yeah.
that's the kind of mentality that leads people to get to these under recovered states where this can happen, of course. And I
Right.
think that's one of the issues. Um, but we can't tell people that something's wrong with them for like just encountering high intra-abdominal pressure in their life routinely.
Right. It's like maybe there's something wrong with your training program or frequency, but there's nothing wrong with you.
Yeah, exactly.
Uh,
Exactly.
I just wear like if sometimes I know when it's gonna happen and I'll just wear a pad or I'll bring one. And if I like
Yeah.
notice it starting to happen as things get a bit heavier, I'll just put a pad on and it's like whatever. It's fine.
Yeah,
And then
exactly.
I mean most of the time it's not happening. So I'm not worried about it. But every once in a while and there's ways to manage it. And pads are an easy way to manage. What do you think about like pessaries? Because I've heard of people using pessaries. It sounds gnarly to me. I don't know. Maybe it's not, but it sounds kind of like extreme to me.
Yeah, I mean, I love them. I think they are great. I think I hope in 10 years that there is even better technology there. I think there's a company out there, please don't quote me on this, but I think there's a company or two out there trying to do custom 3D printed ones too,
Oh, wow.
because one of the challenges is, of course, just like finding the right fit for your particular anatomy. And
Right.
the trial and error can be a little annoying. But a pessary is basically, again, not a visual medium. It's a medical grade silicone, often a ring, but not always a ring, that sits inside. You put inside the vaginal opening, and it sits behind the pubic bone. So if you've ever used a menstrual disc, not a cup, but a disc, that also sits in the same place as a pessary. It's just less rigid. And so it basically just like sits behind the pubic bone so it doesn't get pushed down. And it's just this little support for your pelvic organs. So because it's rigid and
Mm.
because it prevents pressure from pushing as far down on your pelvic organs, it's sort
Mm.
of like a sports bra for, for your
Oh.
pelvic organs.
Oh.
Um, yeah, so the idea is basically like as you generate high intra-abdominal pressure, it mitigates some of that force transfer. And
Okay.
if you leak, it basically like compresses the urethra against the back of your pubic bone
Okay,
and
that's what I
prevents
thought.
leaking from happening.
Okay.
But if your symptom is more prolapse related or your concern is more prolapse related, it has, depending on the shape and the fit of it, the ability to again mitigate the pressures on the pelvic organs towards the vaginal opening. So
Oh,
it
okay.
it can be an instant treatment for urinary leaking. Like it is, if it works, it works. It instantly stops leaking from
Yeah.
happening with stress incontinence. But I also have over the years, for many people, recommended that if they have a medical history, especially like a birth history where they had birth related injury to the pelvic floor, um, and they have concerns around prolapse progression, for example, or it's just a significant enough prolapse that they're bothered by it, a
Hmm.
pessary can be awesome because it just
Oh,
like,
okay.
pardon my language, it just shoves it all back up there and like holds it there. Because there's a hole, right? We can't make the hole go away, but like
Yeah.
it just holds everything there in a way that is often totally not something that you feel. Like it just disappears and it takes that symptom of pressure or sensitivity away pretty quickly too for people.
Uh-huh.
But it also just like is a peace of mind thing. If it feels better to have this in when you go for a run or when you lift heavy or whatever, because you know you're doing what you need to do to try to offset some of the risk associated with high intra-abdominal pressure over time, then like I'm all for it, right? If it's just something you can throw on and you can even wear
Yeah.
for weeks at a time if you want to, but like if it's something you put in and you're like, all right, now I can just go like lift to my heart's content and push myself and not have the voice in the back of my head worried about whether this will come back to haunt me in 10 years, then like fabulous. I think it's great.
Yeah. Yeah. I guess I didn't know completely how they worked. I thought it was just the part where you're saying it kind of pinches off your urethra. I thought that's
Mm-hmm.
all it was about. It sounds uncomfortable to me, but like, I don't know. Maybe it's not. And yeah, for prolapse like that, I didn't realize that like it also like held stuff in. So that's super interesting.
Yeah. So basically, I think the easiest way to think about it is the pelvic organs. So with female anatomy, there's an opening in the pelvic floor muscles so that a baby could come through, right? And the vaginal opening is there. But the pelvic organs, everything's squishy, right? It's all just squishy bags of tissue up there. And so when there is pressure, everything just moves towards the hole, right?
Yeah.
Obviously.
Yeah.
And so, especially for people who have had a vaginal delivery, that opening in the pelvic floor muscles actually widens to accommodate the birth and it's adapted to that. So it stays wider. And there's more opportunity for the vaginal walls to collapse inward under the weight of the pelvic organs.
Mm-hmm. Mm-hmm.
So if we put something inside the vaginal walls to kind of prop back the vaginal walls, then the pelvic organs can't shift towards that hole again. So
That makes sense. Yeah.
very mechanical. It's definitely a learning curve. I myself am like a menstrual disc user, so I'm used to kind of
Mm.
like being elbow deep trying to get that like to sit right.
Uh-huh.
And so I think it's a very personal preference thing, like whether people want to deal with that.
Yeah.
But I think it can get relatively smooth in terms of like putting it in and taking it out.
Yeah, that makes sense. Okay, so that could be an option for some people. But keep in mind, that's not like the fix, right? Like that will help
Yeah.
you manage some symptoms, but it doesn't like fix anything. You still need to strength train and you still, all of that kind of
Oh
stuff.
yeah. But it's also like I've seen it just be this sort of like a permission slip for people. Like
Yeah.
they just like dance out of there being like, you're telling me that I could just like go do whatever I want and not worry. And I'm like,
Yeah.
yeah, to the extent that any of us could do that, like I think that sounds like it would let you just like feel like you've had your insurance policy and like get to move on. Or the
Yeah.
patient that I saw who was like a mom of three and leaked when she ran, and that's all she wanted to do. And she didn't have time to strength train or like do Kegels or anything like that. And I
Yeah.
was like, listen, I just think you need a pessary. She was like, yeah, it sounds great. She went and got one, only had one appointment with me, gave me 100% satisfaction rating at the end, and was like, I'm cured. All my symptoms are gone. Like, it's all because you
Yeah.
told me about a pessary. And for her, she might
Love
use
that.
that till her dying day and like think that her problem was
Yeah.
100% solved because for her it was. So,
Yeah, well, she got what she wanted, she can
yeah,
run. So
exactly.
yeah, that makes sense. Cool. Um, we're like at 2 hours here now
I
almost.
know.
So
I know.
I feel like I wanted to ask you some questions about postpartum. And I also wanted to ask you some questions about like advice for coaches or therapists. Maybe we could save that for like a part two,
Yeah.
unless I don't know if we want to keep going on this podcast right now. Um,
Um,
what do
I
you think?
think in terms of uh, like having a conclusion, I think talking briefly about what people like coaches can do to like close this one makes sense. And then having a
Yeah,
whole postpartum
that
conversation
makes
also makes
sense.
sense. Yeah.
Yeah, that makes sense. Okay. Let me ask you one more question though, when it
Yeah.
comes to strength training. Um, what do you think about belts? I'm a fan of belts. Some people had questions about like, oh, like I only leak when I wear a belt. Like, do you think that's a strategy issue, or like maybe the belt is just too tight? Would be my kind of like troubleshooting thing there, or like maybe their strategy, their position, their brace, their some managing their intra-abdominal pressure differently. Like, what do you think about that?
So I use a belt when I lift. I have not always, but I like doing it. And I think my personal experience has been interesting in that I think I brace differently with a belt on. But for me, it feels like it enables me to brace harder. Like
Hmm.
there's some confidence boost or something neuromuscular. I don't know what it does, but I feel myself bracing much harder when I have a belt on. And I
Hmm.
think the studies that have been done about it are like, oh, it like maybe kind of improves your performance, but I think it changes more qualitatively what people do in a lot of ways or how they feel.
Hmm.
And I think that if somebody is leaking when they are using a belt, like something is obviously changing. And I would, of course, look at fit and then I would look at strategy. Like, does this person do something really weird when they have a belt on that they didn't do
Hmm.
when they didn't? But then if those things check out, then to me, what I would say is like, at the end of the day, the belt is making your core more rigid. And if that's what it's doing, then it's creating higher intra-abdominal pressure for you. And that's your leaking point, right?
Hmm.
So either you have a capacity problem or you have a strategy problem, but like clean up the strategy first, see if it changes. And if you leak, so if you leak at the same weight with a belt and you don't leak at the same weight without a belt, you're doing something with a strategy. Weird.
Right.
That's
Yeah.
affecting you. So I think that's the short story. I don't think belts are the enemy, but I think belts
Yeah.
could let somebody achieve a higher intra-abdominal pressure than they
Yeah.
would without the belt. And that may be just exposing that they have that point at which they will leak.
Yeah. Okay.
But
So
I'm
maybe
inclined
it's,
to say it's more of a strategy thing, honestly,
yeah, I'm
because if they're
wondering.
saying, oh, I only leak with a belt, like, are they like, when are they putting the belt on in their warm up? Are they doing every
Right.
single lift with a belt on? Are they only saving it for their heaviest lift? At which
Right.
point, that's not a controlled experiment. Like, try
Right.
the heaviest lift without it. Yeah, I think there's a lot of reasons, but I don't think there is no rule about you should or shouldn't use
Yeah.
it.
Yeah.
I
Yeah.
think you just
That
have
I
to
feel
use
like,
it well.
yeah, I feel like that would be I mean, my take is belts are great and you don't have to use one if you don't want to, but they can help. And they do help increase intra-abdominal pressure, which can help you brace harder and help you feel like you can lift more weight. I know the research is sort of like, well, we don't know. It kind of seems like people lift sort of the same with or without a belt. But I know personally, like same with you, it helps me feel like I can lift more weight because I feel like I can brace harder. I
Yeah.
like them. If my clients want to use them, obviously I tell them go ahead, but you don't have to. And I have lots of clients that don't. But yeah, that would be my suspicion. I'd have all kinds of questions of like, when are you putting the
Right.
belt on? Like, what is your bracing strategy with and without the belt? Um, like all kinds of things like that to sort of like rule out like what could possibly be happening. So I think those are all things for people to just sort of think about and see if they can also kind of figure out.
Yeah. And bracing strategy is I think so many people are used to thinking about only drawing in as the
Yeah,
strategy for
yeah,
stabilizing their body, that like learning to do a true like Valsalva and like hold it is
yeah,
different. It is different. And you're not going
yeah,
to get narrower when you do it. So you have to like deal with that and like know that that's okay and learn it
yeah.
and practice it and feel comfortable holding your breath. And coming from pelvic floor world, breath holding is often seen as the enemy. And so
Mm-hmm,
people have to
mm-hmm.
relearn how to do this strategy that is very normal. It's an instinctive thing that our body does because it does
Yeah,
work better for the purposes that we use it for. So we actually have to like kind of retrain some of that and give people permission to do that and like do it
yeah,
hard, because that's what you need to do at a certain point.
yeah. That makes sense. I've had people who didn't quite know. Now I'm like, maybe I got to make some content on this, because I haven't found any videos that I love that I can like send to people on it. So I don't know. Maybe I need to make my own. But yeah, a lot of people don't understand how to brace properly, and it's not sucking it in. Like
Right.
that's not bracing.
Right.
It's also not pushing it out.
Right.
Like it's actually somewhere in between. And yeah, it's not a second or a push out, first of all. And I think for some people, I know for me, when I learned how to like Valsalva and like brace when I was a baby lifter, I was like, oh my God,
Mhm.
it looks so ugly when I'm doing it. Like I hate how my face looks. I feel like my stomach looks thicker and I don't like it, which like we shouldn't be having
Yeah.
those thoughts. But I didn't like it. And so I felt like at the beginning, maybe I wasn't bracing well because I didn't like how it looked when I saw a video of myself doing it. And I
Yep.
feel like we have to get over that.
Yeah, I don't think you can look cute while you're lifting really, really heavy weights. I just don't.
No,
I've never seen it.
no, we're not going to look cute, unfortunately. And it's normal to like, even when you have a belt on, especially when you have a belt on, to have like some bulges and things like that. Like,
Yeah.
again, we're not pushing our stomachs out, but like the belt is going to squeeze you?
Right. Right. It's not my best look, but it does work.
Yeah, totally. So I think some of it could be that too.
Yeah.
Okay, let's move on from that. I'm sure we'll get questions, and like I definitely want to do a part two. So if people have questions,
Yeah.
like let us know. I kind of want to wrap it up by just asking you if you have any advice for like coaches or therapists when it comes to supporting climbers or strength athletes with pelvic floor issues. Do you have any advice or any resources or just anything you want to say about that?
I think the biggest problem comes from people being really scared. And again, that's the whole journey of like as a medical professional or health professional, you're encountering your own like weird shame that you have about stuff that you maybe like don't want to talk about in public. Like it's your job to be able to talk about the human body with people. And it's not creepy to ask very matter-of-fact questions about a couple of symptoms that might be of interest to your clients. So, do you have leaking when you lift? Just like say it. You know what I mean? Don't be weird.
Mm-hmm.
Just ask
Mm-hmm.
the question. Don't
Yeah.
like hem and haw and like try to like qualify a million different ways. Like, I think a great strategy is to put it on an intake form. Then maybe you don't even have to say it out loud to people if it's not relevant to them. Like, make sure you ask it because you need to start to get people thinking about it. Even if they don't have that symptom now, maybe they'll have it later and they'll know that they can trust you to come with a question. So I would just make sure that you try to be as neutral about it and as professional about it as possible. And that will help everybody involved feel comfortable because it's just another thing that happens to bodies. And I think we all kind of got to get over the bodies are weird thing.
Yeah.
Bodies are weird and gross and fluids happen and like it is what it is.
Yeah.
So that's one piece. I would also say like I love when coaches are like, "Oh, I got it. Like I don't need my clients to go to a specialist. Like if I run into things, I'll let you know, but like yeah, nothing seems crazy. Everybody has been very upfront with me and we communicate about their symptoms and like I feel comfortable navigating that." Like that's also okay. Like know that that's okay. You don't have to send everybody to a specialist. There are many situations where even one visit with a specialist can really give you some great information and a good starting point to be able to continue working with somebody. And you don't have to like co-treat forever. You can just have a consult and have them get their questions answered that you can't.
Mm-hmm.
I think that's also a great strategy. But as I've said, I have so many clients who have had great success doing very little with me and a lot with other people who are not quote unquote pelvic PTs. And some of the best people that I've ever known and the most smart and the people who get the best results are not people who have pelvic PT in their business card, because they just understand exercise principles. They understand how to communicate with people, and they're not afraid to, ask a pelvic PT colleague to just verify things that they're not sure about.
Mm-hmm.
But I think it's okay to like own that piece of your client's care as well. And I don't think you have to get super in depth in order to be able to just work with people and the symptom that they're having. Um,
Yeah.
with that said, like I think co-treating is really great. Like learning about your work and somebody else's work together in the context of one individual is a great way to learn about a specialty that you don't do. And going to each other for care. Like one of the like most fruitful relationships I've ever had was with a strength and conditioning specialist who we co-treated a lot of people and we worked with each other for each other's needs. And I learned more than I learned in like all of PT school working with her. And she got a lot of confidence to be able to work with all kinds of pelvic floor related symptoms. And she's not treating them, that's not within her scope. But she was just like, yeah, this is a normal thing. Like, I have to be able to deal with it. Like, now
Yeah.
I can be confident knowing what's going on. And I think, in terms of education and really learning and knowing that ourselves as professionals, it's a great way to build a relationship and learn, and swap, like give each other free sessions, like whatever it might be. Like I think that's a really great way to feel more confident on both sides.
Yeah, that makes sense. I think there's a lot people can learn from each other when you work together like that, or co-treat or co-manage a patient or a client. So I think that's, yeah, super important.
And the last piece I would say is like, I hope that people are doing this. Many people are not, but I hope most people are, is uh, putting a critical lens on what they see um, in, I'll say social media, but anything that's like a quick tidbit. Here's a fact about pelvic floor. Here's everybody should do this pelvic floor exercise. No one should do this pelvic floor exercise, whatever. Anything that's not nuanced, anything that's not
Hmm.
in depth, anything that's not well referenced, anything that seems a little bit too good to be true, it's okay to be critical of that. And I think a lot of people feel like they can't be critical of things that are being said by people in the pelvic floor world because they don't understand the pelvic floor, or they think.
Yeah.
But like again, as we've talked about, it is not its own world. Like it does not exist separate from all of the things that good MSK care providers already know and use every single day. And so if something doesn't pass the smell test, like, yeah, like you're allowed to be like, huh, that doesn't really jive with my understanding of things.
Yeah.
And we need to have the same sort of reckoning that we're having in MSK about the way that we work with patients with pain or whatever. We need to have that same conversation happening at the same time with pelvic PT. And I think right now it's a bit insulated from that because people aren't willing to go outside of what they think they already know. But I think we've all got to be part of that conversation. And so I would say, make yourself aware, keep learning, like consume lots of content, like, but always do it with a critical eye. It's not gospel. There's just as many uncertainties in pelvic floor world as there are in MSK world. And yeah, I think we all need to be part of that conversation because I don't think we should relinquish the rules making to
Yeah.
one specialty. Like I think it's all got to be the same conversation.
Yeah, absolutely. And it kind of feels like that right now. It kind of feels like you can kind of say whatever you want when it comes to pelvic floor health because like nobody
Yeah.
else wants to step up and be like, I don't know about that. Like that's not really how it works in the rest of MSK. So like why is that
Right.
working for pelvic floor? No one wants to say that because they're like, well, it's pelvic floor. I don't know, you know?
Yeah,
And I
yeah.
hope people take from this episode like, well, actually, it's not that different. Like, and
It's
we can apply
not.
the same lens to, that information as we do to like MSK. So
Yeah.
yeah,
And
I
there will
think
always be a need for specialists, always. And we know that, right? We're not saying that there shouldn't ever be somebody who just works in the pelvic floor.
right.
Um, but it's not a sacred cow. And it's really like we all need to come from the same fundamental understanding of the way things work in the human body. And just because there's a vagina involved doesn't mean that like suddenly those things go out the window.
Right, right. Well, I think people are going to ask me like, especially coaches and PTs and maybe climbing coaches might ask like, are there any resources or certifications or places we can go to learn more evidence-based information about pelvic floor health? Like, what would you say to that?
I have seen that there are some organizations that are starting to produce a little bit of pelvic floor content. I think I saw it on Clinical Athlete, for example, that there's a bit of content coming out around the pelvic floor. I haven't gone through any of that content personally, but like I sort of inherently trust the Clinical Athlete folks. And so I think that's a
Yeah,
good place to start.
yeah.
Um, I also think that the APTA has an Academy of Women's Health. If you are an APTA member, especially, you can take courses towards a certification to prove that you have some sort of education in this. There's no qualifications required to be a pelvic PT, by the way. I should say that. You could just
Mm,
decide that you were and start doing it, which I think is a
hmm.
huge problem, but that's another story. Um, so you could just take a class. And if you take a class, you're going to have to open yourself up to having pelvic exams and all of the somewhat unpleasant things that come along with being a part of that profession. We all had to kind of run that gauntlet, which is not great, but it's a possibility. And the other thing I would say is there's lots of kind of what I would say more webinar based stuff going on. I know Pelvic Guru is a relatively up to date source for information as well. That's sort of a collaboration between a few different providers. And so you'll get a few different voices there.
Hmm.
But I also think that's a great resource. Um, But I would also say, just like if you're a regular MSK person or a strength and conditioning coach or a climbing coach who is able to hook up with an existing pelvic floor expert in your area, or even not in your area, and just have a Zoom call with them or whatever and build some sort of relationship. If you think that you have a similar philosophy, like I think you and I have had this experience too, is like we know that we're on the same page about a lot of things. And like, you know that you can send people to me, just like understanding already that they're going to get a good message about the things that you care
Right.
about. And like, we're not going to get in each other's way. We're really going to like build towards the same goals with people. And
Yeah.
so I think if you can find that, that's the best learning experience, because then you can have conversations like these and be like, oh, I never knew that. Like now I know, and I can ask this question or whatever. And I think that's really, really valuable.
Yeah, totally. I personally have worked with like other coaches as an MSK provider, and we've shared enough clients that they now know how to help people manage around tweaks or pain. And it's totally fine. Like it doesn't have to be a
Right.
full-on intervention. They don't have to start a whole
Right.
rehab. It's just like, oh, you're having like some back pain or your shoulder pain's coming back. Like I kind of know how to manage around that now because I've worked with somebody who we've worked with multiple clients and have worked through it together. Like I've learned a lot from that. So I think coaches can learn a lot from MSK providers, and MSK providers can learn a lot from strength and conditioning coaches or climbing coaches.
Absolutely. Yeah.
Yeah. Cool. Well, thank you so much for getting on this Zoom call slash podcast recording with me for so long. Obviously, we
Yeah.
have like so much to talk about. There's so much more I want to talk about. So I think we're definitely going to have to do another episode. If you were listening to this and you're like, oh, I really wanted to hear about like postpartum or pregnancy or whatever, we'll try to do another podcast episode talking about that.
Yeah.
But I think this is all still like really good information for you to have as like sort of like a foundation before we go into that episode anyway. So yeah, thank you so much for being here. And yeah, that's all.
Thank you for having me, and thank you for being so excited about this stuff. I don't know if you can tell, it's been a while since I've gotten a chance to really like talk about everything in depth, and I'm just like so happy to be able to talk through these questions in the context of the work that you're doing and the folks that you're working with. Um, yeah, I wish I could shout it from the rooftops. So
Yeah.
everybody should know.
Yeah, it's so fun talking with someone else who's on the same page about stuff. So yeah.
Yeah, yeah.
Cool. All
Awesome.
right.
Well, I'm
Well, we
excited to
will,
come back.
yeah, we'll catch you on the next one.
Yeah.
Okay, bye.